Our second joint community and policy session is now going to begin, and it's now my pleasure to introduce Courtney Lang to talk about cardiometabolic and renal disease disparities. Courtney?
Good morning. If we could have everyone's attention, we're going to be starting our second joint community and policy session. Good morning, good morning. We have some esteemed guests that are with us, and I want to make sure that they have adequate time to present on cardiometabolic and renal disease disparities and update. Our first speaker is Dr. Akinboboye, president of the Association of Black Cardiologists. He is an associate professor of clinical medicine at the Weill Medical College at Cornell University. He has received numerous awards and was selected by Castle County as one of America's top doctors in the New York metro area. He was recognized by New York Magazine as one of New York's best heart doctors from 2006 to 2008, and on the cover of the Network Journal 2008 as one of the best Black doctors in the New York tri-state area. His presentation today is titled Disparities in Cardiometabolic Risk as an Update. He will present first, and then we will sequentially introduce the next speakers. If we could just please have everyone's attention and silence and take the chatter outside the room, I will turn the presentation over to Dr. Akinboboye. Thank you.
Well, good morning. My charge this morning is to speak to you on this topic of disparities in cardiometabolic risk, an update. What I thought I would do is set the stage by starting with definition and description of cardiometabolic risk. Now, cardiometabolic risk is a construct that comprises a cluster of risk factors that are good indicators of a patient's overall risk for type 2 diabetes and cardiovascular disease. It's actually an all-inclusive risk model that's related to metabolic changes with CVD. It accommodates emerging risk factors as useful predictive tools. And really the whole idea is to focus clinical attention on the value of systematic evaluation, education, disease prevention, and treatment. Now, we can break them down into two broad groups. We have the non-modifiable risk factors, including age, race, ethnicity, gender, family history, and the modifiable ones, including being overweight, abnormal lipid metabolism, high levels of inflammation markers, hypertension, smoking, physical inactivity, unhealthy diet, and insulin resistance. Now, let's just put this into play and look at the case of a patient, Mr. Martin, who is a 47-year-old African-American man who hasn't seen a doctor in years. He's a truck driver, eats mostly fast food, smokes a pack a day, was recently found to have a blood pressure of 146/86 and a total cholesterol of 210. A BMI is 29, and he has a family history of hypertension and diabetes. Now, let's just look at him holistically and see what's his cardiometabolic risk. Now, in terms of the non-modifiable ones, his age of 47 puts him at risk. His race, African-American, puts him at risk. His gender, family history. And in terms of the modifiable ones, the BMI of 29, the total cholesterol of 210, a blood pressure of 146/86, the smoking, the lack of physical activity, and his unhealthy diet. And the whole idea is to begin to look at this kind of a patient and not just focus on just the blood pressure or cholesterol alone, but to look at the patient holistically in terms of what they do in terms of physical activity, their diet, whether or not they smoke, and other risk factors. So let's look at the present state of cardiometabolic risk all over the country. Well, presently about 66% of Americans are overweight or obese. We have more than 70 million people with some degree of insulin resistance. There are approximately 54 million people with prediabetes. Nearly 25% of Americans have high cholesterol, and about a third have high blood pressure. Now, let's now look at disparities in these risks. Let's start with hypertension. Now, when you look at hypertension, and we're looking at NHANES data from looking from 2007 to 2010, looking at non-Hispanic whites, non-Hispanic blacks, and Mexican Americans. Men in blue and women in red. You can see clearly that there is disproportionately high prevalence of high blood pressure amongst non-Hispanic blacks. Now, how about overweight obesity? Again, looking at data from NHANES 2009 to 2010, and again, you can see clearly that the prevalence of obesity amongst non-Hispanic blacks is almost 50%, compared to about 35% in non-Hispanic whites and about 37% in all Hispanics put together. So again, another area of disparity. How about abnormal lipid metabolism and dyslipidemia? Well, the good news here is when you look across the board, what is clear is that mean total cholesterol levels, looking at data from 1988 all the way down to 2010, we see a progressive reduction in mean total cholesterol levels across all racial groups. And when you see now that presently, looking at data from 2010, mean total cholesterol is about 192 in non-Hispanic blacks, 197 in non-Hispanic whites, and 199 in Mexican Americans. So here's an area where we actually see a lower prevalence of a risk factor in non-Hispanic blacks. And this is so-called well-recognized black paradox, where in general we tend to see lower cholesterol levels, despite the fact that we know that blacks suffer disproportionately from coronary artery disease. Now, when we look at another index, which is low HDL, HDL of less than 40, defined as HDL of less than 40, looking at non-Hispanic blacks, non-Hispanic whites, and Mexican Americans, again, we see the same picture of we see the same picture of a lower prevalence of low HDL in blacks, and the classical dyslipidemic pattern that we tend to see in diabetes, which include low HDL, high LDL, and high triglycerides. When you look at those indices in blacks, they are slightly different. You see that they tend to be, on the average, lower in blacks than in non-Hispanic whites and in Mexican Americans. These are the numbers for LDL. You look at LDL, again, comparing non-Hispanic blacks and non-Hispanic whites, really no big difference. And when you look at the data for triglycerides, if anything, they tend to be lower also, again, in blacks. Again, this is another example of the classical paradox that we see in terms of predicting diabetes. Because in general, when you see that combination of low HDL, high LDL, and high triglycerides, you can almost predict that this person is walking down the path of diabetes. Because when you actually look at the incidence of diabetes, it is significantly higher in blacks. But when you look at the dyslipidemic indices that what we want to use to predict that diabetes might be coming down the road, they're not there. So one needs to be very careful about using those indices in black patients. When you look at smoking, again, The good news across the board is there is some reduction in smoking rates. Look at non-Hispanic blacks and non-Hispanic whites. They're about similar, less in Hispanics. So what should we do? Well, again, we need to improve our efforts in terms of education, evaluation, prevention, and treatment. Now, we in the ABC have been involved in efforts to work collaboratively with other groups to improve education about cardiometabolic risk. This is the so-called Code Red Consortium, which includes the ABC, Applied Clinical Education, the Endocrine Society, ASPC, NLA. And the whole idea of this concept is to come up with really well-targeted education to improve knowledge amongst providers about cardiometabolic risk. Now, we also have efforts that are targeted at patients. An example is the 7 Steps to a Healthy Heart. Again, this program is being used widely. It's really a set of 7 simple steps, not a whole lot of medical mumbo-jumbo, just simple ideas that we can give patients to help them to modify their risk. I know my time is short. The moderator is looking at me here, so I'm going to stop at this point, and I thank you for your attention. You see that look?
Thank you, Dr. Akinboboye. Our next presenter is Dr. Keith Norris, who's the Vice President for Research and Health Affairs at the Charles R. Drew University of Medicine and Science. Dr. Norris is internationally recognized research investigator and health policy leader who has been instrumental in shaping national health policy and clinical practice guidelines. He ranks among the top 50 most highly funded National Institute of Health investigators in the nation, and among the 3 most highly cited scientists in the area of chronic kidney disease, as well as health disparities. Dr. Norris will present an overview of racial disparities in kidney disease. Join me in welcoming him now.
Good morning, everybody. Good morning. Good to see everybody up and out. These are just, I don't know if you've seen me, these are my conflicts of interest. I try to have as many as possible. That way no one thinks I'm beholden to any one entity. So what I wanted to do is talk a little bit in these few minutes about really some of the social determinants of health, and particularly how they impact individuals who have chronic kidney disease or who may be at risk for chronic kidney disease. And these are 3 main objectives of the World Health Organization. And as you can see, the 3rd one here is develop a workforce and to raise public awareness about the social determinants of health. So I want to focus on just a few of those as an overview for today. Well, if you were missing half of your bicycle, you'd probably notice it. And if you were missing half of your money, you'd probably notice it. Okay? But you could be missing half of your kidney function and you wouldn't know it at all. So one of the challenges with chronic kidney disease, as it is with hypertension and many chronic kidney diseases, is identification and identifying people who are at risk so that we can screen, identify, and start early treatment or intervention when necessary. And it's estimated that between 1 in 8 or 1 in 9 American adults have chronic kidney disease. So it is a very common problem in the United States, and one that we want to grasp and get hold of as much as we can. So what I want to focus on are 2 social determinants of health, very briefly. One is health insurance and its impact on progression to end-stage renal disease, patients needing dialysis or transplantation, and or death, and educational attainment and its relationship to chronic diseases and particularly mortality. So this is a study from the association that was reported in the American Journal of Public Health, and basically what it shows in the smaller light blue bars are deaths averted, potential deaths averted by medical advances, and in the purple, potential deaths averted by education related to education-associated mortality, suggesting that education has a much greater impact as an example of a social determinant on our health outcomes. Now, when you think about education, we think about America being one of the most highly educated countries. Anybody have an idea of what health literacy is in the United States? What percentage of Americans are literate? 20, 30. So it's actually 48% of American adults cannot fill out a job application. 48% of American adults. So when you're talking to somebody, if you think you can, they probably can't. And if they can, you need to reassess whether or not you can fill it out. So we looked at the relationship between educational attainment and mortality in a group of patients that participate in the Kidney Early Evaluation Program headed up by the NKF, the National Kidney Foundation. And we looked at these are individuals who were screened who either had risk factors for chronic kidney disease, high blood pressure, diabetes, or family history of chronic kidney disease, and possibly even had chronic kidney disease. So they go through this screening, and we looked at about 62,000 of these patients who had been screened and what happened, where they were 7 years later. And if you look at the bottom line is individuals who had less than high school education, and that's the probability of survival, versus those that had high school education or greater than high school education. And you can see that among those individuals at risk for chronic kidney disease or with chronic kidney disease, those with less than high school education were much more likely to be dead 7 years later. So death is a pretty hard outcome we look at. And it sends a message that says maybe that could be a potential intervention. It doesn't say for certain. There are other factors that go along with it, but it's something that we can think about when we look at social determinants. Again, in the Kidney Early Evaluation Program, we then looked at about 90,000 individuals, and we looked at what happened if they had insurance or didn't have insurance, and how likely they were to end up on dialysis. And if the individuals did not have insurance, they were 72% more likely to end up on dialysis than individuals who did have insurance. This is among all the individuals who come for screening. And for those who are more familiar with that population, individuals who have advanced chronic kidney disease, not unexpectedly, were nearly 200 times more likely to end up going on dialysis than those that didn't. So again, but an important risk factor, at every stage, pretty much, if you did not have insurance, you were 2 to 4 times more likely to end up on dialysis than individuals who did have insurance. Similarly, we looked at the risk of death. And again, if you were a key participant and you had risk factors for chronic kidney disease and no insurance, you are 82% more likely to die in the next 7 years than individuals who had risk factors for chronic kidney disease but had insurance. So insurance is a powerful risk factor for increasing the risk of patients with chronic kidney disease risk factors or chronic kidney disease dying over the next 7 years from the point in time in which we screen them. And again, patients with chronic kidney disease in general are more likely to die than the general population. And when you're at stage 4 or 5 chronic kidney disease, you're nearly 25 times more likely to die over that 7-year period. Well, why is this important for minority communities? What's shown on the left side of the slide here is our rates of the prevalence of the early stages of chronic kidney disease in red for whites, in blue for blacks, and in gray for Hispanics, and it's fairly similar. So early stages of chronic kidney disease, there are not major differences between racial and ethnic groups. But if you look at who's more likely to end up on dialysis, if you're black in the blue on the right-hand panel, you're nearly 4 times as likely to end up on dialysis, and Native Americans, Asians, and Hispanics are 2.5 to 1.5 times more likely to end up on dialysis. So even though at the early stages, chronic kidney disease appears to be fairly equally distributed among racial ethnic groups, we see the likelihood of ending up on dialysis is much greater for minorities. And for those who heard Dr. Gibbons speak earlier, he talked about the trypanosome-associated gene that is another risk factor that may give some indication that an individual might be at greater risk for ending up on dialysis. So there are a variety of factors, but I think education, insurance, and other social determinants of health are also important factors that influence that happening. When you go to Congress and you talk about these things and you say, well, people are more likely to die, and they say, well, if they die, they don't cost money. That's not. So the question is, what impact does that have financially? Well, the dialysis program costs a little over $40 billion a year. The excess rate of minorities being on dialysis accounts for nearly $10 billion a year additional cost. So in other words, if we could get that rate down to their white counterparts, that program would cost $10 billion less a year. So it does have a financial impact as well. And we throw millions and billions around a lot, and we've become desensitized to it. So 1 million seconds ago was 12 days ago. How long ago was 1 billion seconds? 31 years. Okay? So 12 days ago was 1 million seconds, 31 years was 1 billion seconds. So $1 billion is a lot of money. But I know we see all these numbers in the media, and we become desensitized to it. So in conclusion, for patients with CKD, chronic kidney disease, or chronic kidney disease risk factors, lack of insurance is an important independent risk factor, both for death and for increasing an individual's risk to end up needing dialysis or renal replacement therapy. And minorities in this country have much higher rates of underinsurance or being uninsured. And so this data strongly suggests access to appropriate health insurance is important. And we know now we have healthcare reform, and there's a movement toward universal care. And we may not all agree that that particular program is ideal, but I think it's a step in the right direction, and we do need insurance for as many Americans as possible. So I'll leave with this one little quote. The greatest obstacle to discovery is not ignorance, it is the illusion of knowledge. Thank you very much.
Thank you, Dr. Norris. Our next speakers 3 and 4, I'm very pleased to present. Dr. Jonka Bull joined the Food and Drug Administration in August of 2012 as the director of the Office of Minority Health. Dr. Bull brings extensive public and private sector experience in dealing with a range of product development and diversity issues that is important to this position. As well as Dr. Helene D. Clayton-Jeter is a patient and health professional liaison in the Office of Health and Constituent Affairs, the Office of External Affairs for the Commissioner of the U.S. Food and Drug Administration. She assists in planning, developing, and evaluating FDA policies and programs related to patients and healthcare professionals. Their presentations will be jointly presented: FDA Update, Minority Health, and Patient and Health Professional Outreach, Activities, and Programs. Following their presentations, we will take questions for all of the panelists. Join me in welcoming them.
And good morning, and thank you very much for the opportunity to share with you some of our activities at FDA relevant to cardiovascular and endocrine health, as well as to provide an important update on the work of the office that I'm very privileged to lead, the Office of Minority Health. The key piece that I want to highlight is that it's because of advocates such as many of you in this audience that this office was created. I always like to emphasize that FDA is not new to minority health, but having a dedicated office to focus on these initiatives is new, and we give thanks to those who ensured that this was included in the Affordable Care Act. So if we could advance the slides. Or I advance the slides here. Okay. So our agenda, first, I'm going to provide an overview of the office, our history, goals, and our current activities. And then my colleague, Helene Clayton-Jeter, will provide an overview of the Office of Health and Constituent Affairs, what they do and when. She'll focus on a new program, the Patient Network, and then give more detail on the Cardiovascular and Endocrine Liaison Program. So just briefly to touch on some of the history, Minority Health and the Department of Health and Human Services, historically I think we can appreciate that it has been a bipartisan activity. Many cite its roots going back to 1985 under HHS Secretary Margaret Heckler when the Secretary's Task Force on Black and Minority Health was issued. That led to the creation of the original Office of Minority Health in the department. And I think over the years what we've seen happen is that there's been a march through this recent history that we now have and mandated under the Affordable Care Act of March 2010 that what had been the Center for Health Disparities and Minority Health at NIH is now an institute, and then agencies such as the one that I work for now have dedicated offices of minority health. Also on the heels of the Affordable Care Act, in April of 2011, I'd like to bring your attention to a very important report issued by the department, which is the Action Plan to Reduce Racial and Ethnic Health Disparities. So we are truly fortunate that in the department, one of the leading thought leaders in health disparities and one of the thought leaders in the social determinants of health is the Assistant Secretary for Health, Dr. Howard Koh. And you will hear later today from my esteemed colleague, Dr. Nadine Gracia, who is the Deputy Assistant Secretary for Minority Health. To focus briefly on the office that I lead, our mission is to advance FDA's regulatory mission. Many of you all are aware that FDA regulates one of every $4 in commerce in this country, touching everything from foods to tobacco to drugs and devices. Our three goals are focused on three areas, the first being to advance regulatory science, informing the research and evaluation of subpopulation data associations with race and ethnicity and applications submitted to the FDA. The second, to strengthen FDA capacity to address minority health and health disparities across the agencies and its areas of oversight. And the third, to promote effective communication and the dissemination of information to the public, particularly to underserved, vulnerable populations. An overview of our current programs, our collaborative programs. We have several that are based out of academic institutions ranging from the University of Hawaii to Meharry Medical College to the University of Nebraska. Our HHS partners, we have interagency agreements working with the National Institutes for Minority Health and Health Disparities, as well as with the National Human Genome Research Institute. We work closely, my office is part of the Office of the Commissioner. We work very closely with our component centers, the National Center for Toxicologic Research based in Arkansas, our Office of Regulatory Affairs, which has offices situated across the country, our Center for Biologic Research, and I would like to highlight a project that we have underway looking at sickle cell disease, as well as working with our Center for Drug Evaluation and Research and looking very closely at data highlighting racial and ethnic differences in the science and the clinical pharmacology studies. We also have a program of cooperative agreements, two that are under the FDA Centers for Excellence in Regulatory Science and Innovation based at the University of Maryland and at Georgetown. Would like to spend a moment to speak briefly to the FDA Safety and Innovation Act of 2012. There are three provisions relevant that I would like for us to spend a few moments on. One is Section 907, which mandates that the agency issue a report on the inclusion of demographic subgroups in clinical trials and data analysis and applications for drugs, biologics, and devices. That is required to be issued by July 9th, 1 year after the signing of the bill by President Obama. Section 1137 requires that FDA develop and implement strategies to solicit the views of patients during the medical product development process and consider the perspective of patients. This really focuses on patient-centered work and ensuring that the voice of the patient is well listened to in product development. And then the final one, Section 1138, ensuring adequate information regarding pharmaceuticals. We are actually interpreting this to be all medical products from devices, biologics to drugs for all populations, particularly underrepresented subpopulations, including racial subgroups. And this highlights the issue of health literacy that Dr. Norris referenced, and ensuring that our communications that go out to the public take into account low literacy, English as a second language, and we're definitely very focused and committed on that. So we have a website I encourage you to take a look at. We update it regularly. We have a highlights section, what we call in the spotlight, that regularly is updated to ensure that our constituents, our stakeholders are aware of what's going on at FDA. Just to what I call our bubble slide, just to give you some sense of the numbers of activities and touch points for us in our work. And I will now turn this presentation over to my colleague, Dr. Clayton-Jeter, who will speak to you on our patient programs. Thank you very much.
Thank you, Jonka, and thank you, Gary Puckrin and his team and staff for inviting us here today. It gives me great privilege to continue what Jonka has began for us. I want you to focus on the bubble that says communication and outreach. That bubble also includes FDASIA's section 1137, which is the section that my office, the Office of Health and Constituent Affairs, will be implementing. What this section does, it requires patient participation in medical product discussions. It will build upon a current recruitment, training, and experience of our onboard patient representatives to participate earlier in the product development process. It also will provide for greater awareness of the FDA's patient liaison efforts. So this slide basically is going to tell you a little bit about my office. What do we do? What does the Office of Health and Constituent Affairs do? My office is recently renamed from the former name of Office of Special Health Issues, and we love acronyms at our offices at the FDA, and so I'll be referring to my office as OCA throughout the rest of the presentation. So what does my office do? We facilitate FDA staff engagement with patient and health professional organizations, consumers, industry, and state and federal entities on complex, controversial issues. We advise FDA staff on current opinions of our constituents. We educate constituents about FDA regulatory issues and initiatives. We also coordinate and implement the MedWatch program in our office. We also administer the MedWatch program, which is the FDA Safety Information and Adverse Event Reporting Program. We provide internal coordination on FDA activities related to patient advocacy, health professionals, health professional organizations, consumer groups, state organizations, and industry groups on high priority topics such as serious and life-threatening diseases, imminent public health needs, and other special health issues. I guess I should have titled this slide FDA newest patient-focused activities, because the FDA Patient Network is just that. Just on Friday, we released a promotional video for one of the prongs in the patient network, and that's our website. The multifaceted website that was released, the promo was released on Friday. I want you to take a look at that and see if you recognize the narrator's voice on it. The new FDA Patient Network website.
We heard you, and we agree. Patients should have a bigger voice. The more we interact with each other, the more FDA can help improve people's lives. So we created the FDA Patient Network.
When I came to the FDA as a patient seeking information about access to new therapies, I really didn't have an understanding of all of the factors that the FDA considers to determine safety and effectiveness of new therapies. Once I armed myself with that information and got educated a bit more about the process, then I was really able to make more of a difference for patients like myself.
We're here to help you find what you need. The FDA Patient Network is your gateway.
Now there is a one-stop shop, a resource to learn how medical products are approved and how to engage with real people at the FDA. For patients, it's a place where you can ask questions, where you can learn about clinical trials, where you can find FDA staff who will listen. For patient advocates, it has lots of patient information in one place, such as how to be a patient representative, find ways to speak or comment on disease issues, stay up to date on FDA's patient focus.
So join us on the FDA Patient Network. Learning about your experiences can help FDA make better decisions and improve the lives of all patients.
Get informed, get involved. Help FDA help patients have a bigger voice. Did you recognize the voice? Yes, as of Friday, this was soft launched on Friday afternoon, and there were 53 hits. And I think 2/3 of those hits were either me trying to upload this into my slide or my family critiquing my narration of this promotional video. In addition to the website, we also have a biweekly newsletter, annual meeting. Last year we had that meeting in the spring. This year it will be in the fall. The biweekly newsletter, that was launched on March 2011, and we will also continue to have our listening sessions and other briefings. The next couple of slides are just some screenshots of, I think we've gone too far. How do we go back? I think it's a little out of order, but these are a couple of screenshots of the website. This slide shows how to get involved. We have the drop-down menu to the right, and it shows you where you can go and get information on the patient representative program and on public meetings. Now I want to talk a little bit about a program in which is also new to our office, and it's a program that I have the privilege of managing. It's a cardiovascular endocrine liaison program. This program was the newest program in our office since the 70s. The last program that the Commissioner's Office had the privilege of establishing was our cancer liaison program, and that was back in the Clinton administration. The cardiovascular and endocrine liaison program has been around since the fall of 2011, and I'm very excited about this program because now we'll be investing energies and time specifically to focus on cardiovascular and endocrine disease. What the purpose of this program is to serve as a liaison between the FDA and the cardiovascular and endocrine health professionals and patient communities. It encourages and supports active participation in forming FDA regulatory policies, advancing the safety and effectiveness of human medical products, and treat diabetes, hypertension, and heart disease and obesity. It also promotes healthy dietary and nutritional practices. I see my time is limited here. So the next slide basically goes over our engagement tools, and you saw that we have, we're part of the whole entire patient network. We're focusing on diabetes and cardiovascular issues. We're doing things like, we have a webinar scheduled for tomorrow that will be looking at medical devices, specifically looking at home use of medical devices, cardiovascular medical devices, and diabetes medical devices. I think the two samples that the subject matter experts will be talking about will be glucose meters and I think an artificial heart. I think they'll be talking about that. So that's at 10 o'clock tomorrow. I know you'll be here, but it will be archived on our web pages under the home use medical devices web page. These are just a couple of screenshots of the homepage of the Cardiovascular Endocrine Liaison Program web pages. This is specifically the diabetes homepage. And this is the e-listserv, the e-subscriber listserv that we have. It's called Diabetes Monitor, and we send out information such as this, new drug approvals, meetings that are coming up, notifications, safety notifications. The next slide is of our cardiovascular page, and the same thing, the layout is pretty similar to the diabetes webpage. And this is our Cardio Beat, which is also the listserv for cardiovascular issues. And you can see here we're announcing a meeting that occurred in September 2012. My last slide here is a slide that brings me back to Jonka, my colleague. We both share common educational backgrounds in the ophthalmic arena, and I thought I would put this slide in here to see that we not only have similarities in our educational background, but we are working together a lot to do some things, a lot of great things, to be more proactive versus waiting to hear from our constituents and to try to get out there and bring in the information to the agency, to the places that they need to go. So I thank you so much.
Thank you so much. We'd like to take an opportunity to allow the audience to ask questions at this time for any of our presenters, the president of the Association of Black Cardiologists, Dr. Norris, and then our esteemed guest from the Food and Drug Administration. If there are questions, there are microphones towards the front of the room, and we will take those shortly. I think I'll take the liberty as moderator to ask the first question to Dr. Akinboboye. Just in terms of the consortium with ABC, are there any suggestions or strategies from an advocacy perspective that you would like to encourage the audience to take or participate in as it relates to cardiometabolic syndrome?
Well, thank you for that opportunity. Clearly, in the ABC, in our fight against disparities, we actually have three main pillars. We have education, research, and advocacy. And we are up on the hill a lot, really advocating on several issues. And we often have these Hill briefings that are often indicated on our website, and we definitely would like people to support us in this endeavor, because as we go up to the Hill more and more, we came to realize that actually, the lawmakers actually like that. They want to hear from us. It's not that they don't really want to address these issues. It's that more often a problem of providers not interacting as much as they need to get necessary policies passed. So as we continue with these efforts, we do need more support. I would appreciate that plug.
Dr. Bright, please.
Thank you. For my colleagues, esteemed colleagues at the FDA, question with regard to Findasia, does it have enough teeth? And surprisingly, and questionable, second, when we see drugs that come before the FDA for approval and there is not a level of diversity within that population, will those drugs be sent back for further investigation?
I want to thank you for your question. In terms of Findasia and I think your question centered around the adequacy of representativeness in the clinical trials. I think it depends on the data. I think I'm not aware of an instance where a drug has been non-approved. There are certainly many instances where there have been what are called phase 4 requirements, where additional trials are mandated as a condition of approval to broaden the representativeness of the trials. I think as we learn more about health disparities, one of the areas that I feel very strongly about in my own advocacy within the agency is the need to build better systems for data collection so that we can do the systematic reviews, and if there are differences, that because our systems don't allow us currently to do more in-depth analyses to look for differences, that we have the tools. And I think that you're going to see a lot more work in that space as we move forward because of advances in technology and a greater ability to do those necessary analyses. But a very important question, certainly one that we're taking very seriously and continue to look very closely. Thank you.
If I could add, I know that my presentation was focused mostly on patients and our patient advocacy, but we still do the same thing on the health professional side. So I know that I've conducted a lot of briefings, even post-market, to talk about a lot of issues that health professionals and health professional organizations have concerns. And what we're trying to do, in addition to bringing the patient's voice in earlier, we also want to bring the health professional organization, their views and their voice in earlier into that process, and I think that would help move things along as well.
Andre Carson.
Yes, great presentations. I just had a comment about new codes that are available. Health and Human Services have made new codes available for obesity counseling. So those codes have been out for some time on behavioral health, but providers still aren't aware of them. Those codes aren't being utilized by patients requesting for one of these counseling sessions or providers offering it. How can we promote this in the community so that individuals can finally have counseling to help them deal with their obesity issues?
I'll take it. Yeah, thanks for that excellent question. Yeah, indeed, that's a very important issue. Again, many of the providers out in the communities are very busy. I mean, they see a lot of patients. They're coming in and coming out quickly every 10, 15 minutes. So there's really not enough time to sit down and go into a lot of details about counseling and all that. But there are tools out there that can be deployed. And I alluded briefly to the ABC's interactive 7 steps guide. Now, that guide is actually in the digital format. You can easily download that or gain access to that on our website and actually play that. And that serves as providing adequate information to the patient about obesity, hypertension, and all of their cardiometabolic risks. So, yes, we do need creative approaches like this to help providers provide necessary information to patients. And I encourage people to, again, access our website and look at the 7 steps guide and use it for that purpose.
We have time for one last question. I'm going to take the question over here.
Yeah. 20 years ago, when I began practice medicine, we used to talk about millions and millions of dollars. Now we talk about billions of dollars. And we're trying to implement a healthcare reform. And I wonder why the medicines are more expensive here in the United States and why the cost of dialysis is 4 times more expensive in the United States than in Germany, where the company that makes the dialysis instruments come from Germany, and the company is also a German company. I wonder if the FDA could also not only look into how the medicine should work and how the medicine should be built and what should be the components of each medication and even the size of the bottle. I'm an ophthalmologist. The size of the bottle, whether it's 1 cc or 3 cc's, etc., but also about the cost of medicines.
Okay.
Because we can buy the same medicine in Canada or in Mexico for half of the price.
Okay, so Dr. Norris, do you want to address the dialysis issue? Or just briefly speak to it, and then Dr. Bull, and then we'll just wrap the session after that.
Great question, and I don't know if there really is a good answer. You know, what one would say is the cost of care, as far as the cost of staffing, et cetera, is higher here in the United States than it is elsewhere. Clearly, you know, there's a lot of it is just related to what the system will accept. So there's been a big push, particularly to move to peritoneal dialysis, which should be much less costly, but even peritoneal dialysis in the United States costs about the same as hemodialysis. So it really just comes to, it's really a regulatory perspective around price setting, just as it probably is with the pharmaceuticals as well. Wish I had better answer. It's expensive to live in the United States.
FDA does not regulate the price of medicines. We're cost neutral, and I would have to say, and I think Dr. Norris referred to it, is that sometimes the system cost is based on what the system will bear. I think some of the other countries that you cited have nationalized health care. They may have more cost regulation. There's some, such as the UK, that have systems that take into account cost effectiveness. We don't do that in this country. We're very marketplace driven. But that might be one that, I don't know if there are any in the audience from some of the payers or pharmaceutical companies might be in a position to discuss how price is set. But regrettably, we don't, for FDA's part of it, we look at the science, the safety and effectiveness. So.
Please join me one last time in thanking our terrific panelists.